Hello and welcome to the program. I am Suren. Let me clarify a few things first. In our last program, I have mentioned of a few people and their commentaries and assumptions, theories and thoughts, as well as all their ideas in regards to atheism. However, they were not my own information or based on my personal beliefs, as I do strongly avoid talking about what I think, particularly about the issues of my own theories and beliefs. Although I feel that there may be the opposites to what we all think, for we may believe in the existence of a great God, but opposite may be true. Or we might say that there is no God, no creator, nothing. But we certainly don't know what is out there. Let us therefore remember that ex nihil nihilum. Nothing comes from nothing. However, I found that it is a lot easier to leave at least 50-50 chance for anything and everything that can be. Therefore, it is better to be courageous enough to say, I don't know. Having said this several times, I can still repeat over and over to say, I don't know. I still do not believe that we need a God or a religion or a belief system to be happy. Because happiness, like every other thing, must be born within one's heart first. There's an answer, and that applies to everyone. Research confirms that there is a positive correlation between religion and happiness, particularly in different cultures, such as Islam, where this is considered normal. This study indicates that active religious individuals may experience greater life satisfaction and essential well-being compared to their non-religious counterparts. After all, happiness is a complex emotion affected by various factors, and individual experiences with religion can vary significantly. Let us look at the relationships in more detailed fashion, shall we? What are the benefits of religion and happiness? Question mark. This takes us to the sense of purpose and meaning. Remember, religion can provide a framework for understanding the world, finding meaning in life, and developing a sense of purpose, which can indeed buffer against life's challenges and contribute to overall well-being. However, that is the same with atheism. It is a belief that there is no God. Are we then considering social connection and support? Obviously, we need to take note of religious communities, which often provide a strong sense of belonging and social support, and which can be very important during difficult times. When we consider religions and other belief systems, we are also contemplating the issues related to moral guidance, and positive values. Many religious traditions emphasize virtues like honesty, forgiveness, and compassion, which can provide positive social interactions and enhancing happiness. Atheism is not any different. Clearly, it will be followed by reduced anxiety and depression. However, research suggests that religiously active individuals may experience lower rates of anxiety and depression. Would that mean further increased optimism and hope, perhaps? Let us take it this way. Religious beliefs can provide a framework for understanding suffering and creating a sense of hope for the future, which can contribute to a more optimistic outlook on life. All right, what other factors can we consider? Well, first of all, individual experiences vary. Meaning, not everyone finds happiness or meaning in religion. In reality, some individuals may experience conflict or distress due to religious beliefs or practices. How is that possible? Are there any cultural norms or principles we should observe? Let us not forget that the impact of religion on happiness can be influenced by cultural norms and principles, and indeed social contexts. There are also other factors that influence happiness. Numerous factors, besides religion, can contribute to happiness, including social connections, healthy relationships, financial stability, and personal values. At the end, what religion can be a source of comfort, meaning, and social support. It is extremely important to recognize that happiness is a multifaceted experience. The relationship between religion and happiness is truly complex and can vary significantly depending on the individual's experiences, cultural contexts, and other life factors. What are the relationships between religion and well-being after considering factors such as age, gender, marital status, income, and education? Compared with their less religious counterparts, the actively religious folk tend to be older, probably slightly less educated, and more likely to be female, and probably even married. Such differences raised the question: are people happier, more civic engaged, or less likely to smoke and drink because of their religious activity? Or is it because of those other demographic traits? We discover that to test for the independent effect of religion, PEW Research Center analysts constructed statistical models that evaluate the association of religious activity with 8 measures of individual and social well-being, after controlling and directing the study for age, gender, education, income, and marital status. What is discovered in general across all the countries around the world analyzed, known to be actively religious, is associated with a greater likelihood of being very happy, while belonging to be a non-religious organization, though always voting, drinking only infrequently, and not smoking. In this pool analysis, the actively religious are not more likely to report very good health, nor do they have better outcomes with regards to obesity and exercise. These findings are broadly in line with the results presented earlier in that report. There were other demographic factors that also have close links to well-being. For example, in the regression analysis, being over 40 reduces the chance that one would probably report being very happy or in very good health, or it increases the likelihood of always voting. In here, men are more likely to be smokers and drinkers. Having above median income and being married or cohabiting are associated with greater happiness. Completing college study or university study increases the chance of belonging to a non-religious organization and always voting. We also discover by reading in the reports that PEW Research Center analysts also compared the number of countries in which being actively religious is tied to the advantages of well-being both before and after introducing demographic controls. Generally speaking, the country level patterns shown earlier in this report that connect to religious activity and well-being persist after controlling for demographic factors, particularly when it comes to the measures of happiness and civic participation. In 13 out of 26 countries, both before and after controls, the actively religious are happier than everyone else, that is, the combined population of the inactively religious and the unaffiliated. Hopefully this makes sense. And with the remaining countries, there is not much of a difference between the two groups. Similarly, whenever there is a difference on voting, the actively religious vote more often. In 13 countries prior to controls and 12 countries after controls. And after factoring any demographic characteristics of each group, the number of countries in which actively religious are more likely to join voluntary groups rises from 12 to 14. The smoking pattern also remains similar. Before controls, the actively religious are less likely than anyone else to smoke in 18 out of 19 countries. After controls, the outcome remains statistically significant in 16 of the 19 countries. And in almost all the countries studied and analyzed, there is no connection between religious participation and frequency of exercise, whether demographic characteristics are taken into account or not. That's an interesting discovery. We also discover that the links between religion and self-rated health, obesity and drinking, however, do seem more dependent on demographic factors such as the age and gender. The advantage less religious people sometimes have on the measures of self-rated health and, mind you, obesity, and the unadjusted analysis it is erased when demographic traits of each group are considered. For instance, with no controls, the activity of the religious are less likely than anyone else to report. Very good health in 5 countries, namely Spain, Ecuador, Chile, Estonia, and Slovenia, and only more likely to do so in 2 other countries. Surprise. The US and Taiwan. After taking into account the compositional characteristics of each group, however, no countries remain in which the actively religious are less likely to be very healthy, and a third country in which religious participation is associated with better health emerges, and that one is Mexico. By the same token, before controls, the actively religious are more likely to be obese in 6 countries, as with the Czech Republic, Chile, Slovakia, Switzerland, Poland, and believe it or not, France. But this relationship can be utterly eliminated after controlling for demographic factors. In the meantime, the healthier drinking behaviors of actively religious people are not as pronounced when controlling for other factors, and the number of countries in which the actively religious are significantly less likely to drink frequently drops from 11 before controls to much lesser after controls. In the country, the Czech Republic, active ones are more likely to drink frequently when controlling for demographic factors. Unfortunately, what results from the regression analysis do not perfectly match unadjusted findings. However, they bolster the conclusion that when there are differences between groups, they tend to favor religiously active people for some reason. And some of the outcomes, such as happiness, civic participation, and smoking, these positive links appear in a similar number of countries, both before and after controls been taken into account, and the personal characteristics. In other measures, such as self-rated health and obesity, everyone else initially seems at an advantage. But once the data are adjusted for demographic characteristics, disadvantages fade away. We further discover that the religion can also negatively impact health in several ways, including influencing the healthcare decisions, leading to unhealthy behaviors and causing negative psychological effects. Some religions may encourage dietary restrictions, for instance, that can be harmful, especially when not followed carefully. Religious beliefs can also impact healthcare access and decision making, potentially leading to negative health and the outcomes thereof. Additionally, some religious beliefs may lead to negative psychological experiences like guilt, shame, or fear, which can worsen the mental health. You may find it with Jehovah's Witnesses. There was a time when I was very young and still studying at the university in Germany. Some friends have introduced me to a young girl named Sibyl. Sibyl has suffered at the time some emotional stress and was going through a traumatic experience with her Jehovah's Witness parents, who stopped the psychiatrists and other doctors helping her through with their religious intolerance and convictions, which have been very devastating. At the end, she has committed suicide. Yeah. The situation was preventable, but was not recognized by the cultist ideals or their leaders. One, healthcare decisions and access, influence and treatment. Religious beliefs can sometimes influence individuals' decisions about medical treatments, leading to the rejection of procedures like blood transfusion or refusing treatment based on interpretations of religious texts. However, what about the delayed or limited access? Religious beliefs can sometimes lead to delay or limited access to healthcare, especially in situations where certain medical practices are perceived as conflicting with their religious principles. Again, we consider the witnesses. For example, specific dietary restrictions, as some religions have dietary restrictions that, if not followed carefully, can lead to dangerous weight loss, low blood sugar, or dehydration, according to the study. 2. Unhealthy behaviors, such as substance abuse. Religion normally discourages substance abuse, although some individuals may use them as a way to cope with religious struggles or cultist problems, or as a form of self-medication. What about smoking and alcohol consumption in excess? Well, some religious groups may have stricter views on smoking and alcohol consumption, which could lead to higher rates of smoking and alcohol-related problems. 3. Negative psychological effects. In other words, negative religious tolerance. Engaging in negative religious tolerance, such as believing that illness is a punishment for sin, can lead to increased depression, anxiety, and distress. I will not name any religions here at this moment. There's also the spiritual struggle. Some individuals may experience spiritual struggle that can worsen or even cause mental health issues, especially with those having pre-existing psychiatric disorders. Guilt and shame. Religions can sometimes lead people to feelings of guilt or shame, particularly those who violate religious principles. They are forced into accepting, and which can have negative psychological consequences, as with Jehovah's Witnesses and their policies, such as separating and killing. Tolerance and conflict is another issue. Tolerance and conflict. Some religious beliefs can promote tolerance and conflict, which can negatively impact the mental health and well-being. It is important to note that not all religious individuals experience such negative health outcomes, and many thrive positive benefits from their religious faith and practice. However, the potential negative impacts over religion and health should not be ignored. An article in the Psychiatric Times in January 10, 2010 included the following: Religion, Spirituality, and Mental Health by Simon Dine, FRCP or Psych PhD. He wrote, until the early 19th century, psychiatry and religion were closely connected. Religious institutions were responsible for the care of the mentally ill. A major change occurred when Jacob and his pupil Freud associated religion with hysteria and neurosis. This created a divide between religion and mental health care, and which continued until recently. Psychiatry has a long tradition of dismissing and attacking religious experience. Religion has often been seen by mental health professionals, in the Western societies anyway, as irrational, outdated, and dependency-forming, and as a result, it has been viewed to cause emotional instability. In 1980, Albert Ellis, who was the founder of rational emotive therapy, wrote in the Journal of Consulting and Clinical Psychology that there was an irrefutable causal relationship between religion and emotional and mental illness. According to a Canadian psychiatrist, Wendell Waters, Christian doctrine and liturgy have been shown to discourage the development of adult coping behaviors and the human-to-human relationship skills that enable people to cope in an adaptive way with the anxiety caused by stress. At its most extreme, all religious experience has been labeled as psychosis. Psychiatrists are known to be generally less religious than their patients, and therefore they have not valued the role of religious factors in helping patients cope with their illnesses. It is only in the past few years that attitudes towards religion have changed among mental health professionals. In 1994, religious or spiritual problems introduced in DSM, the fourth, as a new diagnostic category that invited professionals to respect the patient's beliefs and rituals. Recently, there has been a small attempts for systematic research into religion, spirituality, and mental health. Literary articles surged before 2000, identifying about 724 quantitative studies, and since that time, research in this area has increased dramatically. The evidence suggests that the religious involvement is generally conducive to better mental health. In addition, patients with psychiatric disorders frequently use religion to cope with their distress. In recent studies, at least 50% of psychiatrists interviewed have endorsed the view that it is quite appropriate to inquire about their patients' religious lives and that patients' religious concerns have been taken seriously, as an evidence by the fact that the, let's say, American Psychiatric Association had issued practice guidelines regarding the conflicts between psychiatrists' personal religious beliefs and psychiatric practice. The Accreditations Council for Graduate Medical Education includes in psychiatric training requirement didactic and clinical instruction on religion and spirituality in psychiatric care. What then can be said about religion and coping mechanism in schizophrenia? That's a good question. Research in schizophrenia and religion has predominantly examined religious delusions and hallucinations within religious content. Recently, however, religion as an endurance strategy and factor in recovery has been the subject of growing interest. Religious delusions have been associated with poorer outcomes, poorer adherence to treatment, and more severe cause of illness. A number of studies suggest that religious beliefs and practices can be a central feature in the recovery process and reconstruction or functional sense of self in psychosis. On the other hand, Moore and colleagues found that although religion instilled hope, purpose, and perhaps meaning in the life of some persons with psychosis, for others it induced spiritual despair. Patients also reported that religion lessened psychotic symptoms and the risk of suicide attempts, substance use, non-adherence to treatment, and social isolation. Negative psychological effects of religious involvement include excessive devotion to religious practice that can result in family breakups. Differences in the level of religiosity between spouses can result in marital disharmony, and I have personally experienced this with my first marriage. Religion can indeed promote rigid thinking over-dependence on laws and rules, and emphasis on guilt and sin, disregarding personal individuality and autonomy, excessive reliance, ritual and prayer may delay seeking psychiatric help and consequently worsen prognosis. I hope Jehovah's Witnesses are hearing these our words. At its most extreme, strict adherence to the ideology of a movement may precipitate suicide. A secular therapist who does not share the religious beliefs of the patient can still be effective as long as he is alert to the need for sensitivity to religious issues and needing to become educated about the religious beliefs and practices. At times, patients' religious views may conflict with medical and even psychotherapeutic treatment, and the therapist must endeavor to understand the patient's worldview and, if necessary, consult the clergy. It might be thoroughly appropriate to involve members of the religious community to provide support to facilitate rehabilitation. However, you may need to forget the hope for any such help from certain cults, as in the case of the witnesses, which caused the breakdown of my first marital state. Let us consider again religion or spirituality, for they may have therapeutic implications for mental health, and therefore health and happiness. Randomized trials indicate that religious interventions among religious patients indeed can enhance recovery from anxiety and depression, and can cause also the complete opposites. Psychoeducational groups that focus on spirituality can lead to greater understanding of problems, feelings, and spiritual aspects of life. However, the current findings in this study indicate that religion or any other belief system do not have a consistent effect on mental health. This does not mean that religion is not important. The study of faith, beliefs, and practices offer a fascinating opportunity to understand the communities in their cultural context. But findings of the current study do not imply that researchers who are interested in mental health and as with the health professionals should not take any note of their religion and spirituality. Finding does not imply that health professionals should not incorporate religious content and issues that come with it into their work with their clients and patients. However, the study does not support a simplistic assumption that the role of religious faith and practices, whatever they may be, is beneficial for the mental health. For the patient who practice a religious or perhaps spiritual life, health professionals need to carefully assess and address the consequences and potential risks and eventual benefits of their membership, their identity, and practices for mental health. Indeed, there are many considerations in relation to religion and other belief systems that may have relevance to mental health. The distinction between negative and positive religious coping or observation, the role of spiritual struggles and potential positive or negative social consequences, and negative forms of social support, positive and negative interactions of religious service. Attendance need be considered. The quality of religious activities and experiences embrace a wide range of forms, characteristics, and consequences people discriminated against or privileged for or threatened based on their religion, belief system. People who are struggling spiritually, people who embraced the religious life with fanaticism, bigotry, and intolerance. People living a rich and fulfilling life should be taken into account. Not all the religious experiences are the same. Different individuals in different contexts, different experiences need be observed. You can understand your patterns, which are considered as religious experience and practices, and their potential links to psychological outcomes are a very fascinating subject or subjects for future research. And so, we come to the end of this session or episode, and we'll meet you again by the next episode. Keep smiling and be truly happy. Thank you.